Today's question deals with patient education, and I know we've talked about this before in the series, but today we want to get more to the specifics of how we educate patients about muscle physiology and what we're doing with the 180 system. So, as always, it's imperative that we listen to our patients so we can understand where they're coming from and what kind of education level they have. So we have patients that are physicians, physical therapists, chiropractors, massage therapists, some kind of medical background. So with those patients, we can go into a little bit more in depth on what we're doing physiologically. With our typical patient, we need to explain and speak their language more on a little bit lower level, so we understand, or they understand what we're saying. So we have to use different terminology. With patients, typical patients, are we going to go into what a gamma motor neuron is, what an inhibitory interneuron is, afferent pathways, efferent pathways, muscle spindles, actin myosin cross bridges, all that stuff? No. So if we're not going to get into those anatomical and physiological specifics, what are we going to talk about? So once again, we're going to talk their language and we're going to demonstrate. So this is the huge thing that we do with the 180 system. Once we get patients into the clinic, we run through the screen so they know what they can and can't do functionally, so they understand that we're not trying to make them feel better, we're not treating symptoms. Once we get into neuromuscular facilitation tests, and they feel the difference between neuromuscular inhibition and normal facilitation, that's when the light bulb turns on and they get the aha moment and they understand why those things that they were doing with other physical therapists and chiropractors, massage therapists, were actually making them worse, not helping them get any better. Then when we get them back off the table, this reestablishes what we looked at originally, their function. So they understand we're treating them on the neuromuscular aspect to get their function normal. So let's take a look at what this looks like in the clinic. I'm going to put you here. Don't let me take your left leg out. Okay, does that feel weak or strong? Weak. Okay. Compare it to this one. Don't let me pull your right leg out. There you go. I feel weak or strong. Okay, so when I put you in these positions and have you resist, what I'm trying to do is see if your muscle will actually contract. So I'm not trying to see how strong you are. I just want to see if your muscle will turn on. So if you can't stop me, the reason why you can't stop me is because the nerve is not getting the impulse to the muscle to say contract. So when I'm poking around, I'm basically going to where the nerve connects to the muscle belly to stimulate it to turn it back on. So now try this again. Relax. Don't let me take your leg out. There you go. That feels stronger? Okay. No pain? Okay. All right, so that's what we're going to do. Keep on going through here to turn things on that don't contract normally. And even though your pain, it might be somewhere else, it's the other muscle's fault that you have the pain, so we need to turn everything back on.